Thank you all for coming today. My name is Terry Wilcox. I'm the Executive Director of Patients Rising. At Patients Rising, we fight for access to vitals, therapies, and services for patients living with chronic and life-threatening illnesses. If a patient needs it to survive and live a better quality, more productive life, we believe access to those treatments and creating a balanced dialogue in the national conversation is essential. First of all, I'd like to thank our sponsors, which are Celgene, Amgen, and Women Magazine also offers us support, and you'll be getting one on your way out. We have a lovely ad on the back cover, so we're very excited about that. We'll be starting off today. I'm going to introduce you to our moderator. This is Jonathan Wilcox, and we're going to try for all of you who are here to be done as close to 1:30, between 1:30 and 1:45 as possible, because we know some of you have to get back. And if you do have to leave, please, we will not be offended. We know ASCO is busy. Just try to sneak out right over here. Thank you very much, and hope you enjoy lunch, and enjoy. Jonathan Wilcox.
She was going to say Jonathan Wilcox, no relation. I knew that was coming. Welcome to Symphony Center in Chicago. This is a Patients Rising production. Obviously, my name is Jonathan Wilcox. This is the time of the year when ASCO is on so many of our minds, and that's because so many innovative medicines are being unveiled there, and it's exciting. But it won't mean a thing if those innovations don't get out of the McCormick place and into the most important place of all, and that's the hands of patients. We call this program Right Patient, Right Treatment, Right Now, because for us, that's the bottom line. Helping patients fight for, get, and maintain access to the innovative therapies, precision medications, and personalized medicine that they need and deserve. It's a fight worth having, but for too many patients, it's a fight that they're losing when they are facing what we call the barriers to access. These barriers are real, and it's important now for us to find out as much as we can about them. I've asked Dr. Charles Weaver for just that information. This is the CEO of OmniHealth Media, the founder of CancerConnect.com, and a medical oncologist. We've asked him to do something that's not a poll. This is a comprehensive survey and a deeper conversation with hundreds of cancer patients to find out what they're fighting, what they're feeling, and what they're going through. It's the first time this information has been revealed anywhere. I'm honored to have him here today. Please welcome Dr. Charles Weaver. Thank you. Doctor, you've, to me, and even I haven't seen too much of the information, you have brought together hundreds of cancer patients and asked them and said, I said it was not a poll. This is a series of questions, long questions, hours of contemplative thought and interaction to find out exactly, and in a deeper way, what they're feeling, what they're going through. And you have found that these barriers are real. Tell us.
Yeah, indeed. I mean, any of us that have been involved with direct patient care and advocacy, obviously, over the years, have come across multiple barriers to access at a variety of levels. We all have certainly our biases, our perceptions, and our experiences about how meaningful these are. What we tried to do with this survey last week with 420 cancer patients was quantify it in some way that would bring some depth and maybe a little magnitude to the size and scope of the issues that are faced by folks. What you're going to see is, in essence, a preliminary report that was put together for the purpose of the meeting that highlights some of the main things that we discovered, many of which are going to be familiar to you, some of which will probably not. And then we'll follow this up with a much more in-depth analysis, looking more at the crosstabs and the different demographic groups, different patient populations within the survey to try to bring a little more depth and meaning to what we're learning. Just a word about Cancer Connect before we start, which was the vehicle for conducting the research. Cancer Connect is the largest social community of cancer patients online. There's about 50,000 people that have enrolled over the last few years through a variety of websites and directly to connect with other patients, share their experiences, and support each other. And part of what these folks are interested in doing, beyond learning about the disease and supporting each other, is giving back and contributing to the body of knowledge that might benefit more patients. So it was through this vehicle that we conduct polls from time to time, market research from time to time, that this survey was launched and conducted. A word about some of the entities that use Cancer Connect, so you have an idea of where these patients are coming from. We work with both big cancer centers, small clinics, and advocacy organizations to help them create community on their websites. So a lot of the patients that were in this large community that participated in the survey actually are getting their health care at Dana-Farber, Sloan Kettering, Roswell Park, Ohio State, some of the big cancer centers, as well as some of the advocacy groups like the National Ovarian Cancer Coalition, the Myeloproliferative Neoplasm Research Foundation, Patients Rising, and others. And the way the application works is the community actually resides on these entities' websites so that they're providing community to their patients as a service to keep them connected to the cancer center. But once the patients come in, they're actually in a global community of cancer patients that they can connect with around the country to share their experiences and support each other. So about the survey, simply put, we went out with a goal of trying to recruit about 300 cancer patients in 4 days to take this survey and bring this data to you this week. As it turns out, we actually recruited 418 patients that have insurance that came from really 3 hard-to-treat groups: patients with melanoma, multiple myeloma, and non-small cell lung cancer. These groups were specifically selected as opposed to early-stage breast cancer with the idea that they would be more likely to have been exposed to the more cutting-edge therapies, the immunotherapies that are coming into the marketplace, and would be a better gauge of the types of issues that patients might be facing around reimbursement and barriers to access. As I said, the survey was conducted last week, and it really focuses in a macro level on looking at 2 areas of access. One are the financial barriers, and the other is the administrative barriers, which actually can be more cumbersome, as many of you know. So what did we learn sort of as a top-line overview from the study? And I think the cost issue is pretty straightforward and not a big surprise, but in essence, 3 in 5 patients, 61% of those that took the survey reported that their actual premiums increased year over year. So a significant number of patients, just last year to this year, despite what you read in the newspaper, actually had the cost of their basic premium go up. What was interesting to me about this is the greatest number of people reporting an increase were those under the age of 44, which probably reflects at some level the Affordable Care Act's effort to distribute the cost of care towards the younger population as opposed to the older group. If you were under 44 and you had cancer, your premiums increased on average $1,200 a year, just year over year. Okay. The second part of the cost aspect that we looked at was the deductible component. So not only is the majority of cancer patients experiencing a rise in their monthly and annual premiums, they're bearing a higher burden as a result of increasing deductibles. Again, 54% showed that their deductibles had risen over the past 5 years. The younger folks had the highest increase, on average just under $1,600 increase in the deductible component that they're responsible for over the last few years. Even the older population, including myself, 45 to 64-year-old crowd, about $1,000 a year increase in deductibles. So in real terms, when you combine the deductible and the premium increase, younger folks are basically experiencing an increased out-of-pocket direct cost of close to $2,500 just year over year. So, how does this play into the paradigm of accessing newer therapies, novel therapies? Everyone with cancer obviously wants to have access to the most cutting-edge, innovative treatment available to them. That's why they think they're buying insurance, so that should they be afflicted with this condition, they're going to have the opportunity to get the best treatment. And of course, if you ask people, do you want access to the most cutting-edge novel therapies, 86% of them say, yeah, I expect, not only do I want it, I expect to have access to these therapies because that's why I'm buying insurance. But when you step back and ask them, do they understand exactly what that means? Do they understand what drugs are on formulary? The majority, 70+%, really have no idea what's going to be covered in their plan. And they discover this when they go through the insurance approval process, which is the soft barriers to access. So we looked at, sort of the large areas where we thought we'd see the greatest impact in terms of how the insurance process affects access to care. And obviously, when you're diagnosed, the first thing that comes up is prior authorization to your treatment. Roughly 3 in 4, 74% of patients, said that they were required to have pre-authorization before they began their cancer treatment. So irrespective of what the doctor recommended, 75% of people are being told, you have to go back to your insurance company, wait for us to get approval before we can start this treatment. when you dig a little deeper, 82% of them tell you that this actually delayed the onset of their therapy. So you're facing a life-threatening situation, your doctor's recommended the therapy, and now 4 out of 5 can't start therapy because they're waiting to get the prior authorization. We then asked, okay, if prior authorization is a problem, is this a recurring problem? And fully 40% told us that not only did they have to get prior authorization and have a delay of initial time, they had to get it a second time, and 16% actually went through the process 4 or more times to get the same sequence of therapy around treating their cancer. There's a lot of subtle things that impact patient outcomes that result from these sorts of barriers. And one of them is that physicians may quietly or surreptitiously change their recommendations or the therapies they're offering patients because of the way the insurance pre-approval process works. So if you ask patients, 40% of them tell you that they believe that their physician actually might have offered them a different therapy because they didn't want to go through the prior authorization process. I don't know what that real number is, but the perception from the patient community is that it's a real phenomenon. So in concluding, it's pretty clear that the prior authorization process does delay care at some level for a large number of folks. We then asked patients, what percent of you experienced a denial in terms of the recommended therapy when you were through the pre-authorization process? And just over half faced denied claims around the recommended therapy. We tried to quantify how much time an insurance denial takes per denial. And basically, the long and short of it is about 60% of folks consume somewhere between, somewhere north of a half an hour on the phone each time they get denied access to therapy, which kind of surprised me. I think it's probably a much higher number than that in reality. But the data's the data. We then tried to look at another area that's become of concern recently, the idea of medical switching. So the concept here is that an insurance company will require a physician to use a lower cost or an earlier generic drug as opposed to a more recent drug prior to getting access to the more current therapy, and ask patients what their experience was around medical switching. 17% reported that this practice had happened to them. 34% reported that it had happened to someone in the clinic that they were going through therapy with as well. So roughly half of patients, in essence, either had medical switching occur to them directly or to someone that they knew. And of course, no surprise, the patients believe that the main reason medical switching occurs is to control costs, and it may actually prevent the doctor from prescribing the best drug for their situation. Coinsurance also plays a role. As we pointed out earlier, the increase in the deductible component is a pretty major issue, and coinsurance comes into that as well. Roughly 2/3 of patients talked about the fact that the coinsurance actually prevents them from being able to afford the care that's been recommended by their physician. So that, along with the concept of step therapy, are combining to really limit access to the most currently available therapies. And I think it's incredibly important to understand this because, from an oncologist perspective, for me, the last 3 to 5 years, I've seen more innovative, useful products come into the market that prolong people's lives and improve cure rates than really in the prior 20 years. And so you have this incredible period of rapid medical innovation, which is challenging the system, and patients are obviously bearing a large part of the burden of not being able to access these therapies. Lastly, we looked a little bit at what patients' beliefs were about dealing with their health plans, and they weren't overly favorable. 81% said that they believe insurance companies put the burden on them and their caregivers to challenge a denied claim. So in essence, you are forced to be your own advocate, be very aggressive in making sure you get the therapy that's been recommended by your physician. Fully 3/4 of them tell us that they really don't know how to go about the appeals process. Which makes sense. There's nothing in most of our past experiences that would train us to think about how to approach an insurance company when we've been denied therapy that our doctors recommended. Patients believe roughly half the time that insurance companies make errors that avoid them accessing care. The majority feel overwhelmed by the insurance process. And even a third of patients believe that the health plans deny coverage in the beginning to prevent them from getting access to the care they need in a timely manner. So there's a fair amount of skepticism, which again is not a big surprise. I think the magnitude of this surprised me more than the absoluteness of it. So, in essence, short presentation, trying to bring a lot of data to bear for the purpose of today's discussion. But at the end of the day, what does all this mean? Well, it means patients are not getting access to the current therapies in large numbers. And at the end of the day, it really soils the relationship between the physician who's trying to be the patient advocate and give them the best care and the patient's ability to get access to the care that they really deserve. And it, in essence, at the end, imposes an incredible burden on both the patient and the provider, because the provider's spending more and more time dealing with these insurance-related, pre-approval, prior authorization, non-productive use of their time to help the patient get through the system effectively. So we'll stop there, and like I said, it's kind of a quick look. Really just had a week to look at the data, but we'll do a full report, a lot more depth. It'll be out shortly. We'll make sure everybody gets a copy.
Thank you, Doctor.
Yep.
Let me exercise the host perspective, prerogative. Let me ask the first question. You've been a researcher in groundbreaking stem cell research, medical oncologist, a healthcare entrepreneur, and you've done this for the better part of 25 or 30 years. You were surprised about what you found. You were surprised what you saw. And you said not so much some patient attitudes, but just the magnitude. Half of all patients, 3/4 of all patients. These numbers are massive.
Yeah, I think there's two things. I think, for most of the barriers, 30 to 50% of patients experiencing some sort of barrier was a higher number than I expected. But even beyond that, it really works to diminish the relationship between the care team and the patient in terms of optimizing the treatment plan and making sure they get the best care. And that's something, we didn't really measure, but I think that's where the real major part of the problem lies. Because at the end of the day, it comes down to trust. Your patient ultimately needs to trust their physician, they need to trust their health plan, and they need to trust their care network to ensure that they get what's going to be best for them.
One finding I just want to speak to the audience. Half of patients believe that their doctors are not giving them their best clinical judgment because of their relationship with the system and how to navigate through it. It's the development of a credibility gap that would destroy the doctor-patient relationship. And it's something that even you are surprised is going on in this magnitude.
Well, I am, but I can tell you, having also run this social network with 50,000 cancer patients, is there's plenty of evidence in a lot of places about the diminishing trust between patients and both the providers and the health insurance system. The emphasis on cost raises obviously a great degree of skepticism that anyone is really in their camp. And this is just one aspect. We were talking earlier about some of the other things happening in the medical oncology world. There are a lot of other, issues that are below the surface that patients really have no access to that really sort of support a lot of these concerns that you see arising.
Well, we're going back to talk to Charles more about the survey, and we're going to meet a patient who knows exactly what we mean by barriers to access, and I want to hear from all the audience. But first, I want to show a brief video, why access to these innovative treatments is so vital and important.
Terry Barter has come full circle from when he was first diagnosed with multiple myeloma more than 15 years ago.
I didn't expect to be here.
But Terry decided to try something new.
He's the very first patient ever to receive this oral medicine. And I'm happy to share with you that 10 years later now, he remains completely asymptomatic.
No problems at all. Go to work every day, feel good.
That's a message of hope and possibilities, a message of medical innovation at work.
Two special guests. Stacey Worthy is the policy director and attorney with the AIMED Alliance, the Alliance for the Adoption of Innovations in Medicine, and a very special guest, Mark Davis, also a lawyer, Atlanta, Georgia, a multiple myeloma patient, and our special guest today. Please welcome Dr. Charles Weaver again, Stacey Worthy, and Mark Davis. Please. Mark, you said something that I'm probably never going to forget. You said that the most harrowing part of your cancer journey was not diagnosis, it was dealing with the system, the insurance system, everything after that. I'm never going to forget those words, but tell us some more.
Well, you mind if I stand up?
I do not mind.
Life is beautiful, and I'm happy to be here. In fact, I'm happy to be anywhere on this side of the grass. So about 3 years ago, I had a routine physical, and it showed an elevated protein. And my family doctor, who's a good friend, said, we need to do further testing. We did the testing, and it showed an M spike. And that, for those of you that don't know about myeloma, that's sort of an ominous sign. And my M spike was really high in the kappa chains. So I was referred to a hematologist, oncologist at Piedmont Hospital, a very good one in Atlanta. Various other tests were done, bone marrow biopsies, extensive blood tests, and so forth. And indeed, I had multiple myeloma. But it was called smoldering because I didn't have something called CRAB criteria. And so the doctor said, we don't treat that. Meanwhile, my M spike is going up like a rocket ship. And I said, I just can't sit and wait for my spinal cord to collapse and get paralyzed. I can't wait for kidney failure. Isn't there some treatment I can have? And I was referred to Emory Winship Cancer Center and Dr. Sager Loniel in Atlanta. And fortunately, and luckily for me, Dr. Loniel is one of the world experts on myeloma. And so I signed up for a clinical trial, and there's the treatment arm, and then there's the observe arm. Of course, when you're diagnosed with a cancer that is always eventually fatal, treatable, but not curable, there's a lot of fear associated with that. I was very afraid. Then, in waiting for the coin toss, essentially, whether I'm going to be treated or whether I'm going to be observed, I don't think I've ever prayed so hard in my life, that I would be on the treatment arm. Because I'd read a little study done in Spain that said smoldering myeloma treatment with Revlimid is actually efficacious. So I was accepted into the treatment arm, hugely relieved. I mean, still with a terrible kind of cancer to have, but hope. My insurance company was Coventry, still is. And when we submitted the paperwork to Coventry, I received a letter saying, I'm denied. We will not cover the expenses of you being in a clinical trial, which includes a lot of very expensive stuff, such as bone marrow biopsies, all these blood tests monthly, MRIs, and most importantly, a stem cell harvesting, because if you're on Revlimid, they have to harvest after 4 months because your bone marrow gets too suppressed to be able to harvest stem cells. When they denied me, I don't think I've ever been so frightened. I would sort of have a sheen of sweat on my body 24 hours a day with fear. I'd wake up in the night with nightmares, the sheets soaking wet. My wife, Sue, bless her heart, said, well, we'll just pay for it. That's what we saved money for. We'll pay for it. If Coventry won't pay for it, we'll pay for it. And of course, looking at the expense of it, I thought, we'll deplete all our savings. Won't be able to retire. I have a daughter who hadn't gone to college yet. All the expenses of life. My wife will be insecure in her retirement. It was terrifying. I really wasn't sure I'd be willing to pay for it out of pocket. So at the Emory Winship Cancer Center, I told Dr. Loniels, PA, who's a lady named Melanie, just a wonderful person. What had happened? She said, Mark, check out the Georgia Cancer Coalition statute. I believe Coventry has signed on to that, and they have agreed to pay for the incidental expenses of a clinical trial. So I called Coventry. I said, I've got this letter here saying I'm denied, but you've signed the Georgia Cancer Coalition. I have the statute here. You're one of the signers along with Blue Cross and others. I think you need to pay for the incidental expenses of my being on this clinical trial. And by the way, in the letter that I received denying me, they said, well, you can do an administrative appeal. You can do this and that. Being a lawyer, I know what they're talking about is years of litigation, probably in federal court. And by the time that litigation was seen through, I'd be dead. So miraculously, they decided to cover the incidental expenses, and I was able to start with the clinical trial and taking the Revlimid. So 21 days on, just a pill. 7 days off, 21 days on. Each month I go and I have blood work to make sure that white cells, platelets, red cells are good enough to continue on the clinical trial. And lo and behold, within just 2 or 3 months, my bone marrow plasma went to 0. My kappa light chains went from 2,200 to 20, and my paraprotein went to 0. So I've had what they call a complete response in this clinical trial. Thank you so much. It's a miracle. I mean, it's a medical miracle. I love my physicians, my care team. I'm so grateful. So grateful to all these folks. They saved my life. I haven't missed a day of work. I work as a trial lawyer. It's a pretty tough job. I just tried a 3-week jury trial with one of my friends, and that's pretty tough work, jury trials. We won. We got a really good, nice verdict for our client who was orphaned due to negligence. We got a good verdict. So since this happened, I've always lived my life working really hard and playing really hard, and I've sort of doubled down on that because, we don't know how much time we have under the best of circumstances. But I've done very well. Every morning I walk a mile with my dog. I live on a farm in Georgia. Go to work hard. Certain milestones I've been able to enjoy, like my son got his MBA, my son got married, my daughter graduated from high school, my wife and I celebrated our 27th wedding anniversary and went on a trip to China. Every month there's something, and there's have been some professional acknowledgments. I'm not saying this to brag, but I'm just so happy to be, here.
We're happy you're here.
Thank you. So last week, I went hiking in the Canyonlands out in Utah and Colorado with two of my dear friends. One of them is also a Winship patient who was diagnosed with a sarcoma and had surgery. And he and I tried this case together, and when the jury was out, we said, isn't this amazing? We're here waiting on this jury to come back, and neither one of us really should even be here. And it was 2 of us against 21 lawyers. And,
They're going to have to go and get another 40, 50 lawyers, I think.
So, we were just so grateful to be able to exercise our art that we've been doing it for 40 years. And then last week, hiking in the Canyonlands, I'm 64, almost 65, and we were hiking up, 10, 12-mile hikes, altitude 6,000 to 9,000 feet every day, 8-hour hikes over boulders. One of our hikes, we had to climb a 3,000-foot cliff to get out of this canyon. And we just, we felt great. So what I want to leave with you about, insurance companies is I really felt that Coventry had a policy to just deny people to be in these clinical trials because the costs, or the retail costs of this have been over 7 figures. And the deductibles and copays have been expensive too, but I think if they deny a lot of people, probably 90-95% of them just give up. And I was fortunate enough to be at a good cancer center where they know the drill and they know what to tell you. And it's not like I had to litigate with them, but once I said Georgia Cancer Coalition, you signed it, then Coventry paid like they're supposed to. And I haven't had any trouble with them in 3 years. They do what they're supposed to. I get my treatment. I'm very grateful to Coventry. They're not bad people. But I think there's a policy that these companies have, and if patients arm themselves with knowledge, and maybe it's good to go to these big cancer centers where they have experience and know how to work with the insurance companies, your chances are better. So in any event, I'm just happy to be here, and thank you all for what you do, and life's beautiful.
Thank you. Can't let that man leave the stage, I wouldn't think. So I'm obviously, mostly speechless, but let me ask you, you're a trial lawyer, trial attorney. I grew up with one, so I feel like I'm sorry back home at last. And you expressed you had no awareness of these issues, these policies, these regulations, these codes, these covenants. So the expectation that's consistent with your findings, Dr. Weaver, which are that people just simply don't know. They're not going to know. But some attorneys are involved in fighting this. Stacey, these are things that you're seeing more and more often. What do we do about it? And what do you think is going to come next?
So I think the first thing to do is educate people. Make sure that they're aware that there are options for them. So the first thing, all patients should appeal if they're denied coverage. There was a case that came out last week in which a New Jersey insurer was automatically denying all claims for pre-existing conditions, which under the Affordable Care Act, that's prohibited now. But it was an electronic system, it just automatically denied. And even though they knew that that was an error, they let it go through because they knew most people aren't going to challenge that. So as a result, there's a lawsuit in place and they're probably going to be facing millions of dollars in fines. But that is the first thing to do. The other thing that you can do is file a complaint with either the Attorney General in the state or the insurance commissioner. The attorneys general are starting to get aggressive on these issues. So in New York, for example, there were 7 major insurers who were discriminating against hepatitis C patients with just blanket denials unless they could prove that they had advanced liver damage, to the point where their disease had to progress where they would need a liver transplant, which is crazy. So the attorneys general stepped in there and they settled, and now that requirement has been removed. So pretty much everybody has access to that medication now. The other thing to do is you can file a lawsuit. So there have been a lot more lawsuits going on. For instance, in California, there have been several lawsuits for California insurers bait and switch models. So there might be a patient might sign up thinking that they have access to a specific provider, only to find out that the network directory was outdated, so their provider is not being covered. They have the surprise bill. Or their plan formularies changed mid-year all of a sudden, and the medication that they thought they had access to is now dropped from coverage. So there were a couple of California providers who were sued, and they had to pay hundreds of thousands of dollars in fines and millions of dollars in refunds to their consumers. The other step to do is this is piecemeal. So if you sue one insurer, there's no guarantee the other insurers are not going to do the same thing. What really needs to happen is the states need to step in and enact consumer protection laws, which they are starting to do, that specifically address these fail first policies and prior authorization and things of that nature. But until all the states step in and do that, the best options are really these complaints and lawsuits.
Just to add one thing on a more micro level, which is relevant for patients on an individual basis. To your point, most cancer centers and community oncology practices have resources in the clinic, and you need to be your own advocate. Okay, so these are all great things if you want to change policy, but the real question for patients is, how do I take care of myself today for the cancer that I have? And so, be organized, keep track of all your records, talk to your clinic or your cancer center and find out what resources exist. If it's a drug that you know that you're not getting covered, most of the pharmaceutical companies have copay or drug payment programs that will alleviate that expense and make sure you get the drug. And then lastly, there's various advocacy groups, both on a disease state basis as well as globally, like the National Patient Advocate Foundation, that have people that are available to fight these battles on your behalf. But you have to take the initiative to tap into the resources that exist.
I'll wrap it up by saying one last thing, which is you checked off a few things that patients can do. What can you remember? I'm going to give everybody one that'll always work. Be a lot more like Mark Davis. Thank the panel very much.
I went on a clinical trial of a very novel combination, and that remission lasted for about 4 years, which is unheard of. I have to thank my medical institution because they knew that the medication that I'm on is extremely expensive, and so they had already kind of had the resources behind understanding the various ways of being able to assist patients to pay for this. Because when I was first told how much it was, I said to myself, well, I can't ask my husband to pay this will bankrupt us. But there are options, various with, I'm now on Medicare, for instance, and so there's a cap that helps out with that. But more so, that Pfizer does have programs with my particular drug that if you qualify, and there are many different programs that do this, you can get assistance with your drugs. The patient, quite honestly, has to be very proactive. I mean, all throughout this, I've really felt that I've had to go to bat because I've literally been on the wave of innovation. But ultimately, I think the decision about my care and being able to access those drugs completely should rely in my physician's hands and with me as a partner.
Welcome back. We're joined at the panel now with Mark Davis, but of course, Dr. Warren Fawn, the president of the Medical Oncology Association of Southern California. That patient's name is Elizabeth Lacacia, and I wrote down something that she said. She said that this should rely in my physician's hands with me as a partner. Dr. Fawn, in your experience, is anything interfering with that relationship?
Well, number one, I absolutely agree with her. I'm your advocate. I'm the one who should help you get access. And I had a more paternal view of oncology, that it was my responsibility to get access. When I encourage patients to bring in their denial letters, and we'd take care of it. Because we do it every day. And we know that these denial letters are automatic. They're arbitrary. People honestly believe that when these insurance companies deny you, that someone's actually looked at the form. And that's sad. Certainly, I've always felt that I was the patient's partner. And, but I think the key thing is you don't have to be your advocate. You have to just talk to your doctor. We're here to help you. And if you have a good doctor, he will. If you don't have that kind of doctor, you need to switch.
me ask you, your organization takes a particular focus in access to treatments of a high priority. What difference do you think you're making?
Well, over the past years, we've seen the surrender in the war of cancer.
A surrender in the war on cancer?
Yes. In the old days, before innovation, we treated cancer in centralized facilities. But there were huge advances, innovations in therapies. The most significant was Zofran and Neupogen. It allowed cancer to go out in communities. So instead of having one centralized place where people had to travel miles to get to, you had all these places. You had cancer care next to your home. But the Medicare Modernization Act was passed in 2003, which essentially made being a community oncologist fiscally unstable because it paid less for drugs than drugs actually cost us. In 2010, with the Affordable Care Act, there was a little portion there reducing the eligibility criteria for 340B. For those of you who don't know about it, that's a program supposed to be for the poor. But it allowed wealthy institutions to gain access to that program, and it created a wonderful business model. They could affiliate with a poor institution, get 340B drugs, buy up all these unstable oncology practices, and now give these discounted drugs for the poor to well-insured patients, charge full price, and garnish huge profits. So what we're seeing is a huge consolidation in the market. We see government regulations such as MACRA that are hugely complex, that community oncologists cannot deal with. We have to hire staff. There's estimates that $15 billion has been spent just on data collection. So we're seeing a huge consolidation. What does that mean for the patient? Less access, less convenience. It's not as safe. And also, we're seeing poor outcomes because we know that the further people have to travel, the less likely they're going to participate in care. And much to everybody's surprise, the cost of care went up because who do you think is going to be the cheaper delivery system? Mom and pop doctor or these huge corporations with several layers of administration? So it was the whole idea the government was being penny wise, saying, we're not going to give the doctors the money for drugs, but it was pound foolish. And the patient suffered.
Is reform possible? Is it coming? Let's have some ideas.
The answer is no, because of misconceptions that are repeated over and over. One of the biggest misconceptions is your oncologist chooses the most expensive treatment because they want to make more profits. Under the current ASP plus 4.2, which is a reimbursement, if I give you a more expensive drug, I'm putting myself at financial risk. I'm not making any more profits. All the studies show that your doctors have no clue about how much these things cost. So number one, their premise is wrong. Number two, there's been studies that show that when doctors are given free rein, they do pick the most expensive option oftentimes. But the total cost of care goes down. For example, in lung cancer, they're always saying, well, you guys doctors always choose the most expensive treatments. Of course, the cheap one is cisplatin. Cisplatin is one of the most nasty drugs that we have. I don't like giving it. So I'm going to give something that's more expensive, better tolerated. The patient doesn't end up in the hospital. The patient has a better outcome. Seems like a good investment for me.
Talk about, Mark, the doctor-patient relationship. You're the doctor, but it's a patient relationship too. What can a patient do to strengthen that relationship?
Well, I think that my good outcome and maybe my survival was very much caused because my family care doctor was a friend. And I had an elevated protein of only 0.1, and they just changed labs, and it wouldn't even be abnormal under the new labs. And he just sort of had a sixth sense. And he said, Mark, I think we need to do further testing, because he cared about me. And sure enough, once they did is it electrophoresis?
Immune protein electrophoresis.
Okay. where it showed all the different kappa chains, lambda chains, and so forth. I had this enormous M spike. And so Dr. Boyer saved my life. I don't know if we hadn't had that physician-patient relationship, if he would have cared enough to do so. And then I was fortunate enough to go to Emory Winship Cancer Center, where I saw Dr. Sager Lonial. I'd like to adopt him. He's been so kind to me, and he's a world expert, and Emory's only a mile from my office.
And he's already through medical school, so.
Yeah.
Let me ask you quickly, Dr. Vaughn. You want to fight, talked about a war, you don't want to surrender. What's the next thing that we can do?
The next thing you can do is you have to tell Congress that they have to save community oncologists. You don't save money by starving the soldiers.
Wrap it up. Dr. Vaughn, Mr. Davis, thank you very, very much.
People should know that they should try, even though they have not a good attitude and say nothing's going to help me. They should try.
Estelle should know. She has 2 kinds of cancer, MDS and multiple myeloma, and she's 99 years old. When we talked to her in February, for 2 years she'd been on a medication strong enough to fight the cancer, but gentle enough for a woman in her 90s.
You show somebody 99 years old on a cytotoxic drug, how sensitive I am to it. It's pretty wonderful. And then you explain to them how people are doing research on drugs all the time, and they made this wonderful drug that you are sensitive to. It's pretty great. Pretty great.
But Estelle reminds us, medical innovation works best when you are its partner.
Life is a challenge for everybody, every day. Life in itself is a challenge. But it's up to you to augment the good parts.
Estelle is 99 years old. In what framework system would she ever have a chance? This is, in a lot of ways, a panel that I have a specific kind of feeling about. We have an attorney, a PhD, and a graduate of London School of Economics, and yet, of the 4 of us, I am the only one who was ever a college professor. So that's, you can comment about the America's higher education, I think.
Well, I did teach college.
Not like I did, so no. That is Dr. Robert Goldberg, the co-founder and vice president of the Center for Medicine and Public Interest. The other end, Jennifer Hinkle, scholar, sailor, survivor, healthcare economist, and bringing back Stacy Worthy. Please welcome them to the panel. Jen, I'm going to start with you. Last week, you published an op-ed, an opinion editorial in the Las Vegas Review-Journal, and it had a statement a little different than sort of the current conversation. It wasn't so much about patients being worthless. We've heard that before. You're making the point that they are not worth less. What do you mean by that?
Yeah, so I think one of the biggest challenges when we look at these value frameworks is they incorporate measures into them that at the core are essentially saying that it is not worth our money as a society to spend on taking care of these patients. And depending on what diagnosis you might have, whether you're a patient or even a survivor, by plugging in some qualities or some characteristics to a formula, it's basically putting a price on your head. It's putting a number on the value of your life years. For example, in value frameworks, there's an organization called ICER. They're using this methodology, and depending on the patient segment you're in, your life year actually has a different value that is less than 1, so less than a healthy person's in their view. And I just think that this is not a good road to go down for many reasons.
Why would anybody do that?
It's an exercise in health economics to help make trade-offs or decide where money should be spent, how money should be rationed in healthcare. And I believe many of these value frameworks are an attempt to create leverage for insurance companies to negotiate lower prices with pharmaceutical companies. And I also think that they are contributing to what's a bit of a media frenzy, looking at high prices and high costs of care, which is not always 100% accurate when you dig beneath the surface.
Bob, let's dig beneath that surface. You've written a lot about the culture of cost and learning more about it, understanding, and reimagining it in the sense of what a value of innovation means.
Well, listen, these value frameworks are scams. I mean, they're not, they don't measure anybody's value except the bottom line of the people that are defining the value frameworks. And I think what you're alluding to is that all these value frameworks, have two suppositions. One is cancer costs are skyrocketing and we can't afford them. And secondly, the only way we can pay for roads and bridges is by making sure that we get the best quality per patient and that we don't spend more than a certain amount. Now, does anyone here in the audience know how much we spend on cancer drugs a year as a percentage of our healthcare dollar? Anybody? Anybody? It's less than 0.5%. And that number has been fixed for about 30, 40 years. In that time, the cancer survivorship has doubled. So to me, that's pretty goddamn valuable, Jonathan. Let me just say that. On the other hand, what the groups like ICER do, and that's the Institute for Clinical and Economic Review. What this should stand for is the Institute for Continually Extorting Rebates from Drug Companies. Because that quality number that you say, we only can spend $150,000 on to keep somebody alive for 1 year. Well, to push that number down means that the price of the drug that you're going to negotiate goes down. But guess what? There's nothing affordable in that in the patient. That money goes to the PBMs and the insurance companies. I mean, as a matter of fact, I looked at the IMS. The IMS came out with a study of how much we spend on cancer drugs per year. So we spend about $39 billion a year on cancer drugs, which isn't a heck of a lot. You're not going to believe me. You couldn't pave a parking lot in New Jersey for $39 billion, let alone the entire Garden State Parkway. But that's a whole other issue. 30% of that $39 billion goes to PBMs and insurance companies in the forms of rebates. At the same time that the drugs like Mark and others are put on the highest cost-sharing tier. And then at the back end, and shame on the drug companies for not calling this out, then you get copay assistance. So what incentive is there to really develop a metric or an approach to value that keeps people alive longer? So to me, the underside of value is easily measured. It's measured in terms of the time you get to spend with your kids, the time that you get to spend to play baseball, the time. And by the way, the amount that we spend on hospitalization each year for cancer goes down. If we were treating cancer today like we were treating it 20 years ago, with the rates of hospitalization, it would cost substantially much more. So premiums would be a lot higher. As a matter of fact, your premium should go down because you're on new drugs, as far as I'm concerned. So I've rambled on, Jonathan, as I tend to do without medication. So I'm gonna stop here. And
It's the sign of a hands-off host.
Yeah, exactly.
You've heard, wait a minute, hold on. So there's a lawyer here, and a man talked about a scam. Stacey, what do we do?
Yeah, so I think also that I wanted to add about the issue with ICER and these QALYs is that in the U.S., under the Affordable Care Act, the government is not allowed to use QALYs when they're creating prices for Medicare. So if the government is prohibited from using this framework, then why would we use it anywhere else? I think we need to encourage insurers not to use these frameworks because when they do, that's how they justify all of those barriers that we talked about earlier today, such as the step therapy and the prior authorizations. They can justify that because they say, oh, this medication is not worth the price.
One thing, so you've essentially said legally wrong. Bob, you talked about essentially you're morally wrong, but you've made a point about materially wrong. What happens to innovation, like you said, you think in a world of value frameworks?
Yeah, I mean, I think that it's easy to see. We can go look at examples of other countries that use these quality-based kinds of frameworks and look at the kind of investment that's being put into the biotech and pharma innovations in the industry in those countries. And I don't think at all that you see the level of investment and advancement coming out of those industries in countries that have really relied upon the quality. I mean, I'm not saying that there's significant markets for pharma and biotech, but really I see that the US is driving a lot of the investment in this area, and that's because of a structure we have where companies know that they're going to take a huge risk to develop a new product and that they can see a return on the other side. I think in these areas where, or in a world where some third-party player that might be closely aligned with an insurance industry group says, no, actually, we're going to set the price for you. I mean, I think that would be absurd if applied to the US market, and I think it would lead to less investment overall in biotech and pharma, and it would lead to much slower advancement, and many people who are patients and survivors and just waiting to get that next advancement so they can continue to live, they're going to run out of time.
What do you, go ahead.
I was going to say that the quality, there's been studies done, the EU's done studies, it's very simple. You know, you use health technology assessment of quality, it reduces the price, it reduces access, it increases the patient burden, smaller markets, people die, there's less people to treat, so of course your market's going to go down. With ICER, they concluded, and this is the other thing, I think we talked about this in St. Louis, that they said, get this, they said that the reason that drugs for myeloma and other diseases isn't cost effective is because people are living longer. And they spend more money over 5 years on drugs than they other would if they were dead. Now,
What are you, an economist? I mean,
no, I mean, it's like, you know, it's like me trying to figure out why my kids don't put the dishes in the dishwasher, even though here's the sink and here's the dishwasher. How do you answer something like that? You don't. You basically call them out, and as patients, you know, people need to be armed with the kind of facts you're presenting here today to call them out, because they will back off, because it is embarrassing to be caught with your moral underwear hanging out.
Yeah, I mean, ICER kind of leaves out the point that it's a huge economic burden on the US when people get sick and they die before their time.
You can't pay for roads and bridges if you don't have taxpayers.
Right.
I mean, you know.
It's inherently discriminatory against individuals who are elderly and who have serious health conditions.
Yes, and there was a case, Washington State, the state of Washington, had been limiting access to hepatitis C drugs using basically you had to get liver fibrosis, which is what ICER recommended, okay? So when ICER says that we don't, you know, we're not there to inform clinical decisions, they're lying, because Medicare Part B wants to use it, and Washington State uses ICER as one of their technology consultants. The court essentially said, the economic argument doesn't hold here. The job of healthcare is to keep people alive, and you are not keeping people alive by not making these medicines available. So go find the money and do it. So,
Jen, do you see the system turning?
You're
You're out there in the world of healthcare economics, and some behind closed doors and a lot of valuations.
Yeah, I mean, I see a worrying trend. I mean, I've been really surprised to sit both in meetings and on some panels with health economists inside pharma and biotech companies who have maybe come over from Europe now to the US market, and they say, oh, well, we feel maybe the US is a little behind and should be a little bit more like these markets elsewhere. I mean, I don't think that that's a good direction to go in. I think if you look at the UK, and this isn't to bash on the UK or on Albania, but the UK has overall cancer survival rates on par with Albania. I don't see a lot of medical tourism going there for cancer treatment. So I think, you know, do I see it turning? I see that the market is turning towards looking at all these frameworks, but I don't think that they're the answer. I think they're kind of a bit of a false hope for cost savings, and I think that the unintended negative consequences are far beyond what we've baked in or calculated into the way we look at these.
Yeah,
Stacey, legal trends.
Yeah, the UK's cancer survival rates are 15% lower than in the US, and we can't afford that kind of reduction here if we impose the same kind of regulations here.
Bob, final thought. And I mean
people, anything, people here have to, unfortunately, it's bad enough that you have to fight for your cancer care in the trenches, but now that you have these value frameworks overhanging this stuff, people have to, the patient groups have to be very, very organized to push back and challenge the underlying assumptions. I mean, you are worth more. Here's my final thought. When ICER, and it's in there on their website, says we can't spend money on cancer drugs and hepatitis C because we have to pay for roads and bridges, they're saying paying for you to stay alive is a cost, paying for pothole repair is an investment. I don't want to live in that kind of society, and none of us should live in that kind of society. We can take action, we can vote, and we can change these things, you know, a lot quicker than the opponents would want us to.
Question from the audience. Doctor?
Yes, we've been bashing on the commercial insurers, but as you know, the SGR fix was MACRA, and that's a quality program.
That's right.
How do you think this is going to affect care and access?
Well, I think, you know, and I'm actually reading through the 2,322 pages of MACRA. There's good news and bad news. MACRA, it's the authorization,
Reauthorization
yeah.
and CHIP Act.
Yeah, and Jennifer can probably speak to it more than I can, but basically, if I have a commercial insurer, I'm in real trouble if I have a smart provider system, but a provider system is going to have to spend a lot of money to fill in all the blanks, to fill out paperwork before they actually get to patient care. And that's a real problem.
Jan, a final word?
Yeah, I mean, I would just say that MACRA, one of the things it will enable or encourage is participation in alternative payment models. So I think providers, probably with the help of other allies, need to be really pushing what the alternative payment models might look like that would keep community oncology whole, that would make sure that oncologists are appropriately reimbursed for all of the services and products that they provide, and take into account that, you know, there's a huge variation across the country of what the demographics in different practices look like, what the specialties are, what kind of patients, how high risk they are that they're treating, and all of these things really need to be brought to the forefront so that oncology doesn't get kind of like boxed in or lumped in with other specialties or put into models that really can't keep that access to care going.
That rebate money should go to doctors like Dr. Fung, who should be rewarded for keeping his patients alive and healthy. That money should go to doctors and to patients. It shouldn't go to the PBMs.
Please thank this panel. Jennifer, Stacy, and Batlin Bob Goldberg.
Don was diagnosed with cancer 13 years ago. Since his diagnosis, 90 full marathons. Congratulations, Don.
Yes, congratulations. Don is approaching 100 marathons with cancer. Treatment works, and modern treatments don't keep you from work or play or family.
Immune therapy is easy to take. It doesn't hurt.
Don's family benefits too. And for people who say new combination treatments are too expensive,
I'm still working, and I'm contributing to the economy. We travel, we buy food. We recently sold and bought a house, and we pay taxes. We contribute.
and insurance premiums.
Yes, indeed.
And as Don heads off to get his medal, his running shirt says it all.
That was what, 90 marathons mentioned on that video? Don Wright has just completed his 96th marathon, all with multiple myeloma, all as a cancer patient. And believe me, he's on his way to 100. I think this year, just say, we sponsored Don Wright, and I had a chance to, he's not only 96 marathons ahead of me, but I ran with him just for a few steps. And if you could see not just the people that he has touched, because he says, how did he do marathons, Don? He says he talks to people the whole way. And he says, if you could see the people that he has touched and who have reached out to touch him, I think you would realize that patients have a place that is almost indescribable in this space. That is the reason why we are contributing, as ever, to our new resources. Through Patients Rising, we will now be providing special resources, information, and space for information that patients need in order to fight, and as well as the launch of a new website. My wife's the mother of twins, and she has a third child, which is now called the website IcerWatch. And it's a family name, I was going to say. And IcerWatch.org is truly going to be your one-stop shop to find out what's going on, not just from us, but from what others are saying, reports and analyses and correspondence, and we expect to be in this for a long time. Don and Bob talked about St. Louis. I was in St. Louis last week, and in some ways I saw the future, and in some ways it was frightening. It's a future of denial of access treatments for patients, as well as a ceiling on investment in patient medicine. But I also saw something that was actually blew that away, and that's the patient place took hold and pushed back on ICER. And I saw them on their heels, and I know that it is possible. That's why we founded Patients Rising. We founded Patients Rising to stand up for patients, to fight for their needs, to advocate for the access to the medicines that they need and deserve, and tell the truth about health care. The truth is the patient voice is anywhere and everywhere that people will choose to listen to it. And I think you saw all throughout here today, Don and all the others, called on ICER to listen to patients, to truly understand what they're fighting and what they're feeling. Then and only then will they, and even we, truly understand that patients possess a voice and a value that no framework could ever hope to capture. For Dr. Charles Weaver and Dr. Warren Fawn, for Jennifer Hinkle, for Stacy Worthy, for the great Mark Davis, for Bob Goldberg, my name is Jonathan Wilcox. From Symphony Center in Chicago, we thank you and we say goodnight.